Okay, so now it's time for the 2025 Osler Lecture, which is going to be delivered to us by Dr. Susan Galbraith. She's the Executive Vice President of Oncology R&D at AstraZeneca, a clinical oncologist by background with both a PhD and an honorary doctorate, a Fellow of the Academy of Medical Sciences, and she's going to share her thoughts on cancer treatment development.
Well, thank you very much. It's a pleasure to be here. Actually, it's a great honour. I remember when I was Tasha's age, I read a biography of William Osler. I found it very inspirational then, and many of the lessons, all of the lessons are probably still applicable now. So what I hope to do is end by giving you talk that gives you some insight into what's happening in cancer drug development. And I remain extremely optimistic that we can make a big difference to the outcomes in cancer over the next decade or two. But just to start with reality, where we currently are, 5 million new cases diagnosed globally per year. And some cancers we've made tremendous progress in. If you look at the numbers in terms of breast cancer, in terms of 5-year survival, and if you look at haematology. But there are others. We still need to do better in lung cancer. We need to do better in liver cancer and pancreatic cancer. And I think there are opportunities to make a huge difference in many of these diseases. So here's the 5 trends that I see happening that are areas that we're in particular focused on developing medicines for. So the first is that with technology advance in the understanding of how you can link both small molecules and radioactive isotopes to antibodies, there's a whole wave of novel therapeutics coming in that have the ambition to have the potential to improve on the standard of care, which is chemotherapy and radiation therapy for many patients. The second thing is that there's been a revolution already in the introduction of immune checkpoint inhibitors for a subset of cancers that are sensitive to these agents. But this new wave of molecules that are coming into that space that I think is going to segment the currently immune-sensitive space. The third trend is that we now have the ability to create synthetic immunity. With the development of and improvements in protein engineering, we can develop T-cell engagers that can pull in the T-cells into the tumour microenvironment. And we also, with the advent of advanced genetic engineering and cell therapies, have the ability to reprogram cells to create living drugs that actually can home in and identify the cancer cells and kill them at scale. The key, though, is to put all these together into novel combination regimens and not just individual drugs. And that is easy to say and actually quite hard to deliver at pace and at scale. And then the final thing, which is something that is very obvious, which is the earlier you diagnose cancer, the easier it is to produce outcomes that have long-term survival benefit and even a potential for cure for some patients. And we need to improve on the cure rates in cancer if we can use technology to identify cancers earlier. And those technologies are increasingly available. So that's what I see as the emerging trends. Let me give you some examples of how this is affecting cancer drug development at the moment. Let me start with these antibody-drug conjugates and radioconjugates. So again, as I've said, most patients with cancer have multimodal therapy today with either surgery plus chemotherapy, surgery plus radiation, or surgery plus chemo and radiation, quite commonly. But obviously, whilst this is very effective and has been shown to improve survival outcomes, there's a lot of toxicity that's associated with these therapies. And with the advent of antibody-drug conjugates, we have the opportunity to improve the therapeutic index by targeting delivery more specifically to the cancer cells, by improving efficacy, and with the redesign of the cytotoxic elements of these payloads to improve the therapeutic window. And I'll give you some examples of that. So you've got a schematic on the right-hand side which shows this antibody-drug conjugate with a number of molecules attached to it. And again, we've understood a little bit more about what the optimal design characteristics are. Bind to a receptor on the cell surface, internalize, release the payload from the antibody-drug conjugate by cleavage of the linker. And then that's what emerges and kills the cell. But also, for the latest design, These are cell membrane permeable agents that they can go outside of the initial cell and kill bystander cells. So the industry has been putting antibody-drug conjugates into the clinic for about 20 years. And we've gone through evolutions of understanding what is basically a system design of this molecule. So to begin with, people started with giving very highly potent molecules attached. And unfortunately, even when a small amount of these are then cleaved in the peripheral circulation, what you essentially get is toxicity due to that highly potent payload. So that didn't work very well. Then went to actually making sure that the linkers were highly stable, so you got less of that peripheral circulation. But that also doesn't work terribly well to address this bystander effect. And when you're targeting a cell surface receptor, inevitably you've got heterogeneity of the expression of that. And that isn't good. So what we've evolved to is something that is a more better understanding of the system design. The first thing is, in terms of the selection of the target, you need to know what the expression level is on the cell surface. And we need to know that quantitatively. Actually, the best antibody-drug conjugate targets, probably ones that have more than 100,000 receptors per cell, roughly. But it's not just about the receptors on the cell surface, it's about the internalization. And actually, the internalization rate can differ, and that can be important. Then you've got to have this linker technology, and the linkers need to be stable in the peripheral circulation and cleavable in the tumor microenvironment to be optimized. You need to make sure that the potency of the payload is neither highly potent nor lacking potency. There's a sweet spot in the middle. And there's a sweet spot also in the loading of the number of payload molecules and the site-specific conjugation, so you get the specificity of that. And then the ability to cross the cell membrane, so you can have this bystander kill effect. So those are some of the principles that have emerged. 20 years of trial and error and learning. Drug development's hard. You have to be persistent. So I'll give you one example. So this is a drug that targets HER2. Now, HER2 overexpression in a subset of breast cancer in the HER2 amplified, you're talking about 2 million receptors per cell or more, and it's an oncogenic driver. So you've actually got two mechanisms of action that you're addressing with that in that subsegment, which is about 25% of breast cancer. So there's a drug that's already previously approved, which is trastuzumab emtansine, or TDM1, that was approved, and you can see the design of that molecule. It's not got site-specific conjugation, so on average, you get about 3.5 molecules of payload per antibody, but it's variable. It's not got a tumor-selective cleavable linker, and there's no evidence of a bystander effect. Trastuzumab deruxtecan, or TDXD, was an improved design of a antibody-drug conjugate, which has an 8:1 drug-antibody ratio. It is tumor-selective cleavable, and you do get a bystander effect. We tested it head-to-head, and in the trial it was called DESTINY-Breast03, which is second-line setting of metastatic breast cancer patients, straight head-to-head. And here's the progression-free survival data, and there was also an improvement in Gen 2 overall survival at the time that this was presented, with a hazard ratio of 0.28 against an active molecule in cancer. Don't often see that kind of hazard ratio in all these years. So that just, I think, gives you proof of principle that a better design of an antibody-drug conjugate is a better way of developing these drugs. But also, what this molecule can do is actually work in lower levels of expression. So more patients with breast cancer have lower levels of HER2. They're not necessarily the oncogenic driven patients, but about half of all breast cancer patients will fit into what's called HER2 low. So there'll be immunohistochemistry with our semi-quantitative sort of what I call 19th century technology of looking down a microscope and a pathologist saying it's 1+ or 2+. That's what HER2 low is. And in that patient population, it's still better than standard of care chemotherapy. And you can see on the left-hand side the results of the DESTINY-Breast04 study, which was again in second-line to third-line plus metastatic breast cancer with a overall survival hazard ratio of 0.69 in that patient population. And then DESTINY-Breast06 actually included, it was an earlier line of patients, but also included an ultra-low. So what's ultra-low? It doesn't just include 1+ and 2+, but any level of brown on the cell. And just, again, quantitatively, you're actually talking there about probably less than 100,000 receptors per cell. Normal breast epithelium has about 20,000 receptors per cell. So you've still got more than the normal. And in that setting, you still have an improvement in progression-free survival, even in the ultra-low group. So antibody-drug conjugate design can work, and it can beat standard of care chemotherapy. So let me now talk about radioconjugates. And I trained as a clinical oncologist. I gave external beam radiotherapy for many years, and as a drug developer, I've long wanted to improve on the opportunities for improvement on radiation therapy. And I think the whole field of radiation therapy has been optimizing anatomy for about the last 2 decades with better and better designs of machines. But it's still limited by risk to the radiation-sensitive normal tissues, particularly if you're thinking about something targeting in the abdomen with a small bowel or targeting near the spinal cord. With radioconjugates, by putting a radioactive isotope onto an antibody and homing to the cancer cell, you can treat more extensive disease potentially. You could also think about this as a potential for boosting external beam radiotherapy. And the toxicity associated with external beam radiotherapy would be substantially reduced if you only had to give, say, 35 to 40 gray, not 65 to 70 gray, and you could boost with one of these. So I really do think it's got the opportunity to transform how we treat. There is a challenge with this, though, because when we prescribe external beam radiotherapy, prescribe very precisely to a whole volume, and you've got even distribution. When you've got different variability of the expression of your target, you're not going to have the same even dosimetry across the dose. So there's a lot to do here in terms of understanding it. And what's now happening is we're moving from beta-emitting radioisotopes like lutetium to alpha-emitting like actinium-225. And of course, alpha particles got 2 protons and 2 neutrons. They're much heavier. They have a much more rapid linear energy transfer and a much shorter path. So they have the opportunity for an improved therapeutic index. And you can target with all of the same kinds of targets that you can target other things with either peptides or antibodies. So we acquired a company called Fusion Pharmaceuticals just over a year ago that has this actinium-based targeting. And again, what you can see here is that the alpha particles cause dramatic cell damage within the cell where you're targeting it, but also generate superoxides that can spread to surrounding bystander cells. And it's a very immunogenic form of cell kill, so you can have the potential for combination with immune cells or potential with combination with DNA damage response inhibitors. You can distribute and manufacture this. The sources of actinium is complex. I won't go into all of that there, but it is an increasing supply. And it can have dramatic effects, as you can see here, in a patient with prostate cancer. So building on the advances that I've just talked about with antibody-drug conjugates, you've got a whole plethora of drugs that are now coming through the industry pipelines. This is one of ours. I apologize for the name. It's puxitatuxamratican, known as PSAM, if you can't pronounce that. It targets a cell surface receptor called B7H4, and this is some data that we presented at the Society of Gynae-Oncology just recently. And this is a lead actinium-loaded targeting PSMA. And these are data from a trial that shows patients who've had prior lutetium-directed PSMA drug and those that are lutetium-naive, and you see responses in both. And again, quite dramatic decreases that you can see here. We're hoping that the therapeutic index can be wider than the lutetium-based version. And then I want to end by saying, if we're going to use these molecules more broadly, they are essentially targeted molecules. They target a cell surface receptor, and we've got to think about how we're developing the next wave of diagnostics. So we've been investing in a computational pathology approach that uses machine learning, or what I call old-fashioned AI. It's not got generative AI in it, but it's machine learning. You can use immunohistochemistry with a TROP2 assay. This is another target that we're targeting with another antibody-drug conjugate. But what this algorithm does is it can identify on the slide tumor from non-tumor cells. It can then also identify what's the cell surface, what's the nucleus, what's the cytoplasm, and it can give you the optical density, the level of brown, and the cell membrane. and you can create a ratio of the level of brown in the membrane to the level of brown in the whole cell. And we've got a cut point from that. And why does that matter? Well, it turns out that in a randomized phase 3 trial, that actually you have an improvement if you identify these patients with this biomarker. Again, this is discovery. It needs to be validated in another study, but I think it gives you an encouragement that in comparison with the standard of care docetaxel in second-line non-small cell lung cancer, by identifying patients with this kind of biomarker, we can improve and really develop biomarkers. And what we're trying to do now is develop multiplex versions of this quantitative continuous scoring of computational pathology using a foundational model of pathology and help provide multiplex testing for a whole range of different antibody-drug conjugates. So I'm going to move on now and talk about the IO space, the segmentation of the IO space. And this is a depiction, oversimplistic for any of the immunologists in the audience, of the immune system that can adopt different states and decide between the states based on environmental clues. So trained to ignore self through the thymic exposure, can have some immune privilege states such as pregnancy, where you're defending against attacking the fetus, but also you can have the attack version when they're in the presence of danger signals typically. So the problem that happens with cancer is that there's a constant evolutionary war that's going on between the cancer and the immune system that happens over time. And what happens is that you either get into an ignore or defend state. And so there's different therapeutic approaches to try and move back from these ignore or defend states into the attack state for cancer. And one of them, of course, is the immune checkpoint inhibitors that help to overcome the T-cell exhaustion. And so we have two that are next generation bispecific molecules, rilvegostomig on the left, which is a PD-1 TIGIT bispecific. It's actually Fc attenuated, which I think is important in terms of its development from both a safety perspective and an efficacy perspective. Because in combination with chemotherapy in particular, we're seeing a lower discontinuation rate and lower rate of adverse events than some other anti-TIGIT antibodies. And then volrustomig, a PD-1 anti-CTLA-4 bispecific that was specifically designed to have a lower affinity for CTLA-4 than PD-1, so that relatively it only binds CTLA-4 in the presence of PD-1. It was designed to try and reduce some of the generalized T-cell activation that you see with anti-CTLA-4 antibodies and reduce the levels of toxicities such as colitis. So we've taken these into multiple phase 3 studies, and here's some data from a phase 2 study in advanced gastric cancer with the PD-1 TIGIT in combination with chemotherapy, which shows in patients that have got a PD-L1 score greater than 5, really encouraging median progression-free survival, but still relatively small numbers of patients. And then on the right-hand side with volrustomig, PD-1 CTLA-4, particularly in the PD-L1 low a segment of the patient population in diseases like lung cancer, the current checkpoint inhibitors really don't work as well. And in that patient population, what we've seen is quite encouraging, both response rate and maintenance of response over a prolonged period of time with this mechanism, with a lower toxicity burden than we've seen with previous anti-CTLA-4 antibodies. So again, early days, but promising, encouraging opportunity for these molecules. But now let me talk about the cell therapy and the T-cell engagers. So again, the classical immune checkpoint inhibitors I've talked about help to overcome immune suppression. But with the immune cell engagers, we can activate existing T cells within the patient's body. And with cell therapy, we can bring in new T cells to the outside that can help overcome resistance and make tumor types that are classically not thought of as immune sensitive actually respond to these new therapies. So let me just start with some of the data that we've shown. So this is a molecule targeting, well, it's a cell therapy targeting anti-GPC3 or glypican-3, which is a cell surface receptor that's expressed on hepatocellular cancer in particular. And here you see the design of the chimeric antigen receptor. You've got the binding element here, transmembrane domain, and then an intracellular portion that has a co-stimulatory molecule as well as the CD3 zeta chain. What this cell has that many cell therapies that have been tested to date in solid tumours have not had, and I think is really key to success for solid tumour-based cell therapy, is an armouring function. So solid tumours particularly have an immunosuppressive microenvironment, and many of them have a high level of TGF-beta, which is a very immunosuppressive cytokine. So this also has a TGF-beta dominant negative receptor, so that it doesn't matter how high the level of TGF-beta is, it won't respond to that, it won't suppress its function. And what we've seen here is very encouraging 56% response rate and good durability of response for about 7 months. And again, you see an example here in a patient with extensive disease and liver metastases. So proof of principle in a late-stage patient population that cell therapies can work in solid tumours. But if you take these drugs, these living drugs, and you take them into the earlier stages of the disease, they can be even more efficacious. This is an example in a hematologic disease of a dual CAR targeting two cell surface targets, BCMA and CD19. We think that's important because the currently approved CD19-based therapies can have escape, and the currently approved BCMA monotherapy targeting cell therapies can also have antigen escape. In this patient population, small numbers of transplant ineligible, newly diagnosed patients with multiple myeloma, we had 100% complete response rate and 100% MRD negativity rate at 6 months. I'm not used to those kinds of numbers in oncology, so that's really quite impressive. So this is now moving on from the cell therapy to T-cell engagers. Can you produce the same kind of responses that you see with cell therapies, which are very complicated to produce and deliver to patients? And can we simplify that whole process by having biologics that can deliver this? And this is a bispecific CD19, CD3. It's got a modified CD3 affinity, so a lower rate of cytokine release syndrome. That's the idea behind it. And we published these data at ASH last year, showing really promising activity in a third-line, late-line patient population with follicular lymphoma. And again, with a two-step-up dose regimen, low rates of cytokine release syndrome and low rates of the neurologic side effects that are sometimes called ICANS that you see associated with this kind of modality. So what we want to then do, and this is oversimplistic, forgive me, is put together some of these elements of what we've talked about in the portfolio into combination regimens that make a difference. We want to look at the combinations of the immune checkpoint inhibitor molecules I've shown you with antibody-drug conjugates and with radioconjugates. And we hope that this will lead to further improvement in the long-term survival. So some initial data. This is the TROP2 antibody-drug conjugate. I showed you some data from lung cancer. This is now triple-negative breast cancer, combining this drug with a PD-L1 antibody. Unprecedented levels of responses in triple-negative breast cancer. The individual drugs on their own produce responses in the 25 to 30% range. So this is unprecedented. The durability looks really encouraging. And similarly, the same combination now in lung cancer, either as the doublet or in combination with platinum chemotherapy with impressive response rates. And we're now taking these into phase 3 trials in all of these settings. So let me end by talking about the early intervention. I think there's, fundamentally important piece. I'm pleased to see that we're rolling out lung cancer screening across the UK and many other countries, but it's still only targeted to those that are at high risk. And people have been nihilistic about the treatment of lung cancer for a long time, but I see no reason for us to be anymore. We're still accepting outcomes for lung cancer that we would never accept in breast cancer, and I don't see any reason why we should accept it. I think there are things that we can do. The biggest issue is the late diagnosis. Too many patients are diagnosed at this stage 4 rate where you can see these are the overall survival curves. If we can stage shift through screening and earlier identify into this point, you can have much better long-term outcomes. And this is something that we can, We have the technology to make a difference here, and we can make a difference. So let me give you some examples. This is the results of a trial called AEGEAN, which is in the perioperative setting. It uses the PD-L1 inhibitor durvalumab in combination with neoadjuvant chemotherapy, and then followed by some adjuvant treatment after surgery, compared with neoadjuvant chemotherapy and then surgery. And what you see is, first of all, an improvement in pathologic complete response rate, so absence of any viable cells at the time of surgery, from 4% with chemotherapy alone to 17%. That translates through to an improvement in event-free survival, which you can see here, a hazard ratio of 0.69. And importantly, one key question is, do you need the durvalumab if you've had a pathologic complete response? And it's early days yet. There's multiple trials with multiple companies putting these kinds of molecules in. Overall, I still think there are some patients here that have had a pathologic complete response that will benefit, but we need better tests to identify those that will. In those without pathologic complete response, you also see a continued separation of the curves. So I've mentioned better testing, circulating tumour DNA. The technology for this is improving. The sensitivity of these tests is improving. And this is an example of the fact that if you can identify those patients who are circulating tumour DNA positive at the time of surgery, those that are low or negative have a really good prognosis. Those that are high probably need some extra treatment. We're testing this in an ongoing phase 3 trial for the Tropion-Lung12, looking at the combination of the ADC and the IO in this setting. And these patients have outcomes currently that are similar to patients that routinely get adjuvant chemotherapy at the moment. It also appears that if you take these combinations into the neoadjuvant space, when you've got the tumour in situ that can still act as its kind of own vaccine, that you can have even better efficacy. These are data from a neoadjuvant phase 2 trial called the NeoCOAST-2, where we've taken this combination of an ADC targeting TROP2 and durvalumab plus platinum chemotherapy. And if you compare it to the pathologic complete response rate we saw for the AEGEAN trial, which was 17%, we're now getting a 34% pathologic complete response rate and a very high rate of major pathologic response, which has nearly the same kind of EFS outcome as those patients with pathologic complete response. So to put all of this together, our strategy is to understand as much as possible about the diseases that we're treating, and we're using AI and digital technologies at every point of discovery and development now. So we're partnering with a company called Immuno-Oncology, which is developing an AI model of the immune system to better inform which patients should benefit from which kind of immune therapy. We're partnering with a company called Tempus in the United States that has a large number of patients where they've got the genomic data, the pathology data, the imaging data, as well as the electronic healthcare record data anonymized. We've actually developed a digital health division of AstraZeneca, still fully owned by AstraZeneca, but operates not just with us, but with other companies that are developing digital health tools that will help, I hope, reduce some of the burden of participation in clinical trials and the management of those patients and the support of their adverse events. And then we're investing at scale in computational AI-based pathology tools to improve the diagnostics that we're doing. And to put this together, we've deliberately built a diverse portfolio of drugs on the right-hand side: antibody-drug conjugates, radioconjugates, DNA damage response, tumor drivers, and epigenetics that kill cancer cells directly. And on the left-hand side, drugs that overcome the immune exhaustion or create synthetic immunity to kill cancer cells indirectly through the immune system. But we also need to think about how we diagnose patients earlier, how we monitor them through the disease, and how we adapt therapy as they go along. I do believe that data and AI is going to transform every aspect of drug discovery and development, and it's doing it faster than I could have imagined. And digital health is going to be important to help support our patients through all of this. So with that, I want to end and say thank you very much for your attention. I'm happy to take any questions. Thank you.